due to my brilliant management, we have 5 minutes left for questions. But are there questions for Tom while we have him on the line? I know there are a couple in the chat. Tim?
Real quickly.
Yeah.
So within our community, sleep disruption patterns are a common characteristic.
Refrain, yeah.
Are there examples, my daughter, for example, knock on wood, I'm so fortunate, but she's sleeping 11 to 12 hours a day.
Wow.
And we have to kind of wake her up. Are there examples on the other end of the spectrum that we're aware of in the community? Or is that, the majority I know we have real sleep issues, but are there examples?
Sort of what they call polysomnia, where there's extended sleep. And I don't know, Tom, if you know any, Tom.
Just a question.
Yeah. Did you hear that? Are we? Can you hear us here in? Okay. She's taking charge. Oh, okay. But so sorry. Okay. The question was: are there those individuals with extended sleep? Tim was just saying that his daughter. You carry on.
Is an example. So knock on wood. We're so fortunate,
Yeah.
but she will sleep 10, 11, 12 hours a day. Are there any examples of that in the DLG4 community that we're aware of, or is the vast majority, I think, are sleep disruptions?
The data we have about this 50 patients, well, it is kind of the other way, not as your daughter. She just sleeps, yeah. Okay, so there are other, yeah, but I think that's the reason why we also in our database, I mean, this questionnaire I'm talking about, we have very kind of detailed questions, so it will give an idea.
Yeah, wonderful. Tom, I don't know if you can hear us here in. No, you can't.
Yeah, not so. I can hear some of the questions,
Okay.
but I can't.
Okay, I guess the question was: there are two Shine kids who have extended sleep. They sleep up to 12 hours a day, and are you seeing that as well from your experience, Tom, at all? Or?
Yeah, so we can see that sometimes, particularly. It's this idea of sleep consolidation. So if you have, sometimes what can happen is that if you have a longer period. If you have more fragmented sleep, you end up filling a longer period. So, if we said for a typical kid, let's say 9 hours of sleep, just as an example, not necessarily that's what you should have. But if it's broken up, the brain and the body will try to put it into the appropriate spot. Right. Vice versa, sometimes if the sleep window is exaggerated because you either have a circadian mismatch. So for a while, your battery's telling you to go to sleep and then your battery's charged, but your internal clock is telling you to go to sleep. Then you can end up with the same problem where you have the window is not matching what your sleep needs are. Both of them can be problems. And sometimes that's a reason to try a sleep consolidating medication in conjunction with. And then, without knowing the exact specific scenario, closing that sleep window. So you have a shorter window but more consolidated sleep.
And probably an unfair question, when you look at sleep consolidation medications, is melatonin one's first stop? I mean, obviously they need to talk to sleep specialists initially, but is melatonin the least worst option often, or?
So melatonin is best for adjusting the timing of sleep, because when you take melatonin, the half-life is very short. It's less than an hour, right. And your brain is using it, like when we had that slide, the brain is using it to regulate the timing. Right. So if you do have too much of a window and you're saying, well, this sleep is not really fitting the normal schedule, then melatonin would be an option, but it'd have to be given at the right time.
Right.
And there are sleep consolidating medications that are useful, but some of the medication, and this is where it's frustrating, some of the kids that we've tried the medications that usually work in other neurodevelopmentals don't have good success in DLG4, unfortunately.
right. And I will continue talking. Oh, here we go. A question over here. And a microphone? Yeah, thanks. Yeah, well done. She does everything.
Thank you. So I have a question about focal discharges, so no epilepsy per se. My daughter last year, she showed that she has focal discharges, and the architecture of her sleep is preserved. So I was wondering if the discharges could affect the quality of her sleep, or if it...
So just so I'm clear, she's having focal discharges, but her
Yeah.
sleep architecture
Is preserved. Yeah.
Okay. And so your question was?
So do the focal discharges affect the quality of her sleep? She is also showing HDHD symptoms, so I was wondering.
So is their sleep quality affected by these focal discharges, even though it looks like the architecture is preserved?
Yeah.
Okay. Lucky you, Dr. Dye. Do you have any thoughts on that?
Yeah, so this is something that we would like to learn more about, because we certainly see patients with DLG4 and other genetic neurodevelopmental disorders that have a relatively high burden of sleep, of spike wave discharges during sleep, and then have sleep-related symptoms during the day. And in those scenarios, it's anecdotal at this point, but we've had pretty good success in using sleep consolidating medications that are not necessarily focused on treating the discharges themselves, but treating the fragmentation of sleep with improvement in daytime function. So it somewhat depends on how, what the burden of the discharges are. They very frequent? And also kind of what the symptoms are during the day.
So speaking with a sleep specialist at some point, which is not easy in England, I guess would be the next thing, right? And when one talks about the sleep consolidating medications, that's a short-term 1 month, 2 month thing, and everything gets a bit better? Or we're talking about these kids are going to go on for the foreseeable future, Tom?
Yeah, if most of the time it's long-term. A lot of times what we'll do is a kind of a medium-term month, particularly if there's, behavioral aspects. So, parents have to sleep. So if you have a kid who's got a sleep disorder, you're doing everything you can to get some sleep.
Right.
And in the short term, it might be beneficial, but in the long term, they're going to have behavioral sleep issues, sleep onset association. They can't fall asleep without your presence, which means they can't stay asleep without your presence. So a lot of things like that. And if you treat with a medication in a short window, you might be able to make some of those behavioral changes and then reevaluate after maybe 3-6 months and see if you can come off the medication. For other things where we're saying, hey, there is disruption from an electrophysiology standpoint, we're treating with the medication the same way we would treat epilepsy. It's a long-term problem, then those are more likely to stay on for a longer term.
Great stuff, thanks.
Dr. Dyer, can you give us examples of those sleep medications, like names maybe? I mean, we could take it back to our own doctors, but any type of examples of sleep consolidation medications?
Nothing from Purdue Pharmaceuticals, please, but
Just,
yes, right.
I know, and generic names would be fine because we have international.
Absolutely. Yeah. So when we think about this, you can either take your foot off the gas, that's decreasing wakefulness, or you can put your foot on the brake, that's increasing sleepiness. So some of the ones that have been used quite widespread would be medications that work on histamine receptors. So that would be medications like trazodone and doxepin. Those are older tricyclic and heterocyclic antidepressants that work for sleep. They work by kind of blocking histamine receptors, which are wake promoting. So if you have a kid who's waking up a lot in the night, those can be useful for sleep maintenance, but they also help with sleep onset. If you're thinking about, a kid who's very has a lot of ADHD symptoms, they hit that second wind period, and they're really ramped up in that period before going to sleep. A medication like clonidine, which is an alpha adrenergic that works by decreasing that fight or flight response, can really help with the sleep transitions. And sometimes kids will take that in like 4 o'clock, to help help. It's not as effective with sleep maintenance, but it is useful for the sleep onset. There's other newer medications that we have, you know, I say this, take this with a grain of salt. I don't know if the Palmers are there, but there's a medication we have very good success with other kids with neurodevelopmental disorders, but not so far with DLG4, but that's the dual orexin receptor antagonists. And those are newer medications, but very effective in some children that have sleep fragmentation and have the benefit of not interacting with other medications. But I say that with a big grain of salt. And then lastly, there's if you're having a lot of difficulty with the timing of sleep and the melatonin strategies aren't working, there are melatonin receptor agonists, Ramelteon, which is generic. There's Tazimelteon, which is cost prohibitive for just about everyone in the world, but those work by binding melatonin receptors and can really help to reset the internal clock if that's the main issue.
Great.
And there's other medications. Yeah. A lot of times, if you're overlapping with epilepsy, some of the anti-epileptics can be useful. But
that's a great list, Tom. Thanks very much. For those that don't have access to a sleep specialist, are there other resources that they can look at that you can think of at all, or no? I mean, web-based things at all, or no?
Yeah, it's really, really tough.
Okay.
Let me think about that.
Right,
maybe
you
I'll
can get
send
back
an
to us.
email.
Okay,
Yeah.
there was some question. Yes. Yes, you're
Tom,
loud.
Is there any publication which kind of describes what the medication you have been mentioning? If you are able to send it to me, I can just share it with the community, or you can just do it directly.
Yeah, sure.
Yeah.
I mean, some of my colleagues, actually Sharon Tamir, who's speaking, and her and I wrote a paper about this last year. So.
Cool.
Okay, great.
If you could just spend the rest of your day focused on helping us out with this, Tom, we'd really appreciate it.
Yeah.
Okay.
Yeah, my kid's tablet time is just going through the roof.
I'm just going to ask, we have a question from the chat for you, and then an additional one for the others. So I'll start with you so we can let you get going. So how can you test for seizures if your child is taking lorazepam for catatonia?
Yeah, that's a good question. So we have, when we do EEGs, we often have, kids that are on anti-epileptics. When catatonia often has, as you're aware, obviously, that quite high doses of benzodiazepines, and those can cover up certain, those can treat seizures, but also cover up epileptiform discharges. But if you interpret the EEG in that context, if you say, hey, this is an EEG being done while on high dose benzodiazepines, that is, that influences the way that you interpret the EEG. So if you had an EEG, for example, that had maybe like 25% discharges versus 90% discharges, but you said, well, hey, this 25% discharges would probably be much higher if there wasn't a concurrent lorazepam or clonazepam or something. So it's just more about interpreting it in the context of the child's medical treatment.
And is there another question, Sabrina? Thanks, Tom. We're really making you work for your money here.
No, happy to, yeah.
Okay, Tom, thanks very much. We really appreciate you dialing in and being so helpful.
Yeah, absolutely. Thanks again for the invitation, and I look forward to the next meeting.
Okay. And
Thank you. If there's questions for the other speakers, we can ask them now. I have one in the chat.
Go ahead.
I'll start there.
Yeah.
Okay. Because I think everyone wants to go to lunch. So, so the question is, and this will probably be for Zainab and Katina. So, is there any insight from the phenotype studies or the understanding of PSD95 as to loss of motor function, mobility in adulthood, and its cause? And then the second part of that question is, what makes some variants more common?
So I think the mobility issue is both genetic and also it is related with, when the child is immobile, then it affects the mobility more. So if it's not activated in one way, so it's kind of continuing thing. And for example, scoliosis is also related very much to immobility, and the hypotonic children, it's not easy to mobilize them. So this is both genetic, but also it's also kind of added afterwards. This is one thing. Why we see some variants more often is that I think it is kind of by chance, especially for the DLG4, and it is. I think if everything is saturated, we will probably see again more variants, recurrent variants, and it is also common for a lot of neurodevelopmental disorders. Some variants are recurrent, even though they are de novo. It means that they are not inherited in families. So I think it is kind of by chance, and there is also some genetic reason, because some of the changes of the amino acids and the letters of the nucleotides is more prone to changes, that the changes are not kind of specified. But it's very, very genetic and very complex to define or tell it without drawing on a table.